Well, good morning. This is Dr. Richard Jonas in Washington, D.C. I'm Emeritus Professor of Surgery at George Washington University School of Medicine, and I'm delighted to be participating in this symposium. So, I've been asked to speak on the topic of deep hypothermic circulatory arrest in neonatal surgery, and specifically asked the question, is it a safe option? So this is the structure that my talk will take. We are going to review the history of deep hypothermic circulatory arrest. We'll look at studies that define optimal technique of circulatory arrest, both clinical and research, how to monitor a safe duration of circulatory arrest, and when and how to use circulatory arrest in 2025. So open heart surgery actually began with circulatory arrest. It was Lewis in Minnesota, 1952, who closed an ASD after using surface cooling and hypothermic circulatory arrest. So this is how he did it. The patient was placed in an ice bath, cooled to about 28 to 30 degrees Celsius, and then placed on the operating table. The chest was open, clamps were placed on the cavers, and there was enough safe arrest time of, say, 15 to 20 minutes to close an ASD. It was given in Philadelphia, who introduced the heart-lung machine, and this led to a number of groundbreaking, pioneering operations in Minnesota at the Mayo Clinic by John Kirkland and by Walt Lillehei at the university. And interestingly, both Kirkland and Lillehei did not have good outcomes with neonatal surgery using early heart-lung machines. Lillehei had a comparison group who had not been exposed to cardiopulmonary bypass. This was his fascinating series of repairs using a parent as an oxygenator, where he obtained really very good results for children less than 1 to 2 years of age. Why the difference? Well, it was the damaging effects of cardiopulmonary bypass from early heart-lung machines that had huge priming volumes of several liters. And in those days, whole blood was used as the priming solution. So there were lots of deleterious effects of these big machines designed for adults: emboli, hemolysis, inflammation, and limited oxygen delivery. And hence the concept of delayed repair with initial palliation became standard practice in the 1950s and 1960s, so that a child would be larger by the time they had their repair with a larger blood volume. Now, industry responded to these problems by beginning to develop hardware specifically for infants. This was the Bentley bubble oxygenator that we used at Royal Children's in the 1970s when I began in this field. They had a smaller priming volume, but they still had a tremendous number of emboli, particularly gaseous microemboli. And that opened the door to the concept of deep hypothermic circulatory arrest in the 1970s. Because now, with the introduction of prostaglandin, newborns could be diagnosed and resuscitated and taken to the operating room in relatively good condition. And it was Barrett Boys and Castaneda who popularized this concept of early primary repair using circulatory arrest. And both these great surgeons were my mentors and will most certainly explain my enthusiasm for early primary repair. So then, to summarize, the fundamental rationale for the development of circulatory arrest was that neonates and young infants are particularly susceptible to the deleterious effects of bypass. Using circulatory arrest shortens exposure to those deleterious effects. And furthermore, neonates and infants are particularly able to tolerate circulatory arrest because they have multiple adaptive mechanisms to hypoxia and ischemia. The newborn brain, for example, is ideally suited because of limited synaptic development, limited myelin, and many metabolic adaptations, such as mitochondrial metabolic pathways and fetal hemoglobin. And those adaptations are there because of the low oxygen environment of the normal fetus, because of placental oxygen transfer and so on. But note that these adaptations are lost after about 4 to 6 months of age. Now, by the 1980s, we had a membrane oxygenator that was specifically designed for infants, and there were improving cannulas and other hardware involved in cardiopulmonary bypass. It was now more suited for infants and newborns. And we also had a new operation, the neonatal arterial switch operation was primarily an extracardiac operation, one of the first of the newborn operations that was primarily extracardiac. And so we were in a position where we could directly compare the outcomes with circulatory arrest versus continuous bypass. And I was certainly honored to be able to work with Jane Newberger and David Bellinger on the Boston circulatory arrest study between 1988 and 1992. So we enrolled babies with transposition, with or without a VSD, less than 3 months of age, all at Boston Children's in a prospective, blinded, randomized clinical trial. We enrolled 171 patients over that 4-year period. You can see that about 3/4 of them had an intact ventricular septum. Now, the primary perioperative outcome was that clinical seizures were more common if we used circulatory arrest. And as you can see, this was particularly true if you had an associated VSD. Note that looking at the occurrence of seizures versus the duration of circulatory arrest, that no patient with a seizure had an arrest time of less than 35 minutes. And for the intact septum group, really, you had to get out to 40 to 50 minutes before you reached a point of inflection where clinical seizures became important. Now, a lot of people focused on these early outcomes, and there was initially some association between motor skills, not IQ skills, but motor skills at 4 years of age were lower in patients who had perioperative EEG seizures. And so this really had a big impact on the field in the 1990s, and most people moved away from using circulatory arrest at all. However, they didn't follow the continuing outcomes, which actually documented that there were no differences in IQ motor skills between continuous bypass and circulatory arrest for all patients, including any of the 13 subtests. And that continued to hold true out at 16 years, and these patients continue to be followed. So in this report from 2018, you can see that there were really no important bypass variables, including the duration of circulatory arrest, that influenced not only the neurodevelopmental outcomes, in other words, IQ and motor skills, but also psychosocial health status. With respect to academic achievement, at 8 years of age, there was also no difference in school results between patients with circulatory arrest and those with continuous bypass, though there was a lower score slightly than expected for this population of patients. And really, by this time, we were beginning to understand that congenital heart disease, particularly the more severe forms, was not infrequently associated with some degree of developmental delay. And there were a lot of factors that contributed to this, and not just the use of something like circulatory arrest. There are genetic factors, abnormal fetal circulation, compromise at delivery. Of course, as surgeons, we could do studies to look at the factors that would allow us to improve surgery and the techniques of bypass and circulatory arrest. And so that's exactly what we did. At MIT, we were able to use the National Magnet Laboratory and placed piglets inside the bore of these large magnets. These were the early days of magnetic resonance spectroscopy. And over many years, we determined, just to summarize it, that bypass is still not a normal physiological state. And in fact, the techniques of bypass that we were using at the time of the circulatory arrest study were often dangerously limiting oxygen delivery. Specifically, reduced flow rate during cooling, long arrest times, a very alkaline pH, and hemodilution to 20% or less. All of these factors came together to potentially limit oxygen delivery to a dangerous degree. Let's just briefly look at pH strategy as an example. So in the 1960s to 80s, we added carbon dioxide. This happens to be called the pH stat strategy. It's a more acidotic strategy. But in the 1980s, there was a shift for various reasons, without any clinical studies, I might point out, to the more alkaline alpha stat strategy. And sadly, shortly after we made that shift, we began to see more kids with chorioathetosis that hadn't actually been seen for many years, and reported a study on that, and also performed a retrospective neurodevelopmental outcome study. You can see that with the more acidotic pH stat strategy with higher CO2s, there were improved developmental outcomes relative to the more alkaline strategy. This led to a prospective randomized trial that followed the circulatory arrest study, and essentially all perioperative complications were more common with the alpha stat strategy, including even death and bleeding, and including clinical outcomes like the time ventilated, time in the ICU in some subgroups like the large transposition subgroup. What about hemodilution? Well, early heart-lung machines, as I pointed out, were primed with whole blood. But by the 1980s, there was increasing pressure to reduce the exposure to bank blood because of the discovery of HIV and hepatitis C, increasing cost of testing. And so the standard for the day was to use a hematocrit of at most 20%. So we undertook a randomized clinical trial of hematocrit after our piglet studies at MIT showed us that this was probably having an impact on brain metabolism. And this study did document that motor skills, the psychomotor development index, was significantly worse if you used a hematocrit of 20%, showed in the blue, relative to a higher hematocrit of 30%. So just then to summarize, I think the best clinical evidence that we have that circulatory arrest is indeed safe in neonates and young infants are these two prospective randomized trials shown here. The Boston circulatory arrest study, in spite of its limitations, but now having 33 years of follow-up for some patients. And there's another randomized trial, the one conducted by Ed Bove's group, that compared continuous antegrade cerebral perfusion with circulatory arrest for the NORD procedure. And just last month, they documented that even with 10 years of follow-up, and there'd been no differences with earlier follow-up, but going out to 10 years, there were no differences in neurodevelopmental scores between either continuous perfusion or hypothermic circulatory arrest at either 5 or 10 years of age. So what do I recommend in 2025 for newborn perfusion strategy? Well, we have improved oxygenators, improved cannulas. We understand techniques of bypass like hematocrit, pH strategy. We have better monitors like continuous venous oxygen saturation, near-infrared spectroscopy. So I would personally use continuous bypass for neonates more than about 3 to 3.5 kilograms. But if you have a preemie less than 2 to 2.5 kilograms, placing cannulas in the cavers can cause cable injury, thrombosis. You can you need further cannulas because of left heart return. You're dealing with fragile tissues. And so I think these are good patients for hypothermic circulatory arrest. You can use a single cannula, which you can remove during the arrest period. You have small structures, so the arrest time is short. You don't have a big VSD to close. It's going to be quite small. Cooling and warming are rapid because of the small body size. And near-infrared spectroscopy is particularly accurate with a less calcified skull. And you can design modules so that you can minimize arrest time. For example, transposition with VSD, place a single atrial cannula if you have like a 2-kilo baby with transposition of VSD. Do the first 3 modules, divide the great vessels after aortic clamping, coronary transfer, aortic anastomosis. Then take the cannula out. You can close the ASD and the VSD, and then put the cannula back in and do the pulmonary anastomosis during rewarming. So what's a safe duration? How long can I arrest for? If anybody tells you a specific number, then I would question it, because certainly all of our work documented that it varies according to the bypass conditions. So if you're warmer, if you're more alkaline, if you have a lower hematocrit, then the arrest time will be shorter. In addition, we have improved monitoring with near-infrared spectroscopy, which allows us to predict a safe duration. And this was a study that we reported in 2001. And just to quickly take it through it, this red line is piglets who had a hematocrit of 30%. And during this arrest time, they decayed their oxyhemoglobin determined by near-infrared spectroscopy. In the green and yellow, these lower hematocrit animals reached a plateau. So a point of inflection defined the beginning of what we call the nadir time, basically a plateau where you're no longer extracting oxygen until you go back on bypass. And that oxyhemoglobin nadir time was very predictive of histologic and functional injury in piglets undergoing circulatory arrest in our studies. If you had a nadir time, so that's that plateau period of less than 25 minutes, there was no evidence of behavioral or histologic evidence, and these are blinded neuropathologists, in any animals. And remember that the total safe arrest time includes that decay time. For the red graph that we just looked at, it never got to a nadir. So the arrest time there was out to an hour with no evidence of histological injury. So once again, the nadir time and therefore safe arrest time is going to vary according to hematocrit, pH, and temperature. So in conclusion, improvements in cardiopulmonary bypass hardware and the techniques of both circulatory arrest and cardiopulmonary bypass have reduced the advantages of circulatory arrest over continuous bypass that were there when first introduced by Barrett Boys and Castaneda back in the 1970s. The two most rigorous trials of circulatory arrest versus continuous bypass in newborns show no differences in late outcomes. There are important technical advantages of circulatory arrest when it's used in preemies, like less than 2 kilograms, for example. And with a careful design of an operation, sequencing operative modules appropriately, you can reduce circulatory arrest time to less than 30 to 40 minutes, which with appropriate temperature, pH, and hematocrit is almost certainly going to be fully safe. So thank you once again for the invitation. I really appreciated the opportunity to participate.
Thank you, Dr. Jonas. There's no one better to give that talk than you. I believe you're online.
Yeah, good morning.
Good morning for you. Any questions for Dr. Jonas?
Excellent presentation, Dr. Jonas. One question, beyond the neonatal period, the same principles, are they valid, or, do you change your pH state versus the alpha state? Which method do you prefer beyond the newborns?
Personally, if I were using circulatory arrest in either an adult or a child, I would use the pH stat strategy and add carbon dioxide. It is important to work with a perfusionist who is comfortable with the technique, who's had experience with it. But I think just understanding the fundamental principle that if you make the blood very alkaline, and particularly if you go beyond alpha stat, for example, then what you're doing is vasoconstricting the cerebral blood vessels, and you also shift oxyhemoglobin dissociation to the left. So hemoglobin hangs on to oxygen, and you're making it more difficult for the brain to extract oxygen. So it simply makes sense to have a more acidotic strategy when you are stressing the situation by using circulatory arrest.
Yes. I'm asking this question because we have sometimes some cases with aortic arch stenosis, very complex, especially in shunt complex. And in these cases, I prefer, the deep circulatory arrest.
Yeah.
Yeah. And for this reason, I'm asking the question. Yes.
Yeah, well, definitely. I think many of the factors that I talked about are also operative in adults, and that there's no reason to go to an alkaline strategy when you're using circulatory arrest in adults.
Yes. Thank you very much.
Dr. Jonas, I had a quick question. In terms of the time to cool to get your achieved core temp in your studies, is there a proper time? Because some people cool pretty quickly. Is there a time you want to spend to actually cool that patient down to your achieved temp?
No, I don't think there's a specific time. I do think that you should avoid using very rapid cooling. I mean, in the days of the circulatory arrest study, we would cool a neonate down over perhaps just 10 or 15 minutes. I think that was pretty rapid. The reason we could do that is we were using wall water. In other words, we could just turn on 4-degree water straight to the heat exchanger, and that resulted in very rapid cooling. So that was part of that perfect storm that I talked about. where we had very rapid cooling. We used arrest times of an hour, and the hematocrit and the pH and so on. And in spite of those factors, once you got out to 16 years, there were absolutely no differences in outcomes, in clinical outcomes between the two groups. But nevertheless, I would say based on near-infrared spectroscopy and so on, you'd be better off prolonging your cooling time to at least 20 minutes or so.
That sounds good. Once again, thank you so much for joining us. We appreciate you coming on live to answer some questions also.
No, absolutely. I enjoyed yesterday's presentations as well in the middle of the night. Thank you.
Excellent. Thanks for joining. Thanks, Dr. Jonas.
Lovely. Thank you.